The AOA's Evidence-Based Optometry Committee released the second edition of its clinical practice guideline, Eye Care of the Patient with Diabetes Mellitus, which was first published in 2014. With us is Dr. David Mellitus, co-chair of the development group for the second edition of the AOA guideline. And also with us is Dr. Lori Grover, a member of the AOA Board of Trustees whose background is in public health, and she was also one of the original co-authors of the first guideline. Welcome, doctors.
Thank you. It's great to be here.
Thank you. Thank you for having me.
As you both know, diabetes has reached epidemic proportions in this country. According to the CDC, more than 30 million U.S. adults have diabetes, and many Americans don't even know they have it. That's particularly relevant for doctors of optometry, as the eye is often described as the veritable canary in the coal mine when it comes to detecting diabetes. Several years ago, Dr. Mellitus opened his practice, the Diabetic Eye Center, to care for diabetic patients in Utah. What are you seeing in your practice, Dr. Mellitus?
Diabetes is always referred to as an old age disease, except if you're juvenile diabetes or type 1 diabetes. Well, what we're seeing now is that the young children are having type 2 diabetes. And one of the causes for that is the sedentary lifestyle and also the poor eating habits or poor diets. And because of that, we're seeing a greater number of young patients being type 2 diabetics, not because it's necessarily a genetic predisposition, but because it's a lifestyle issue.
How young are we talking?
We're talking as young as junior high, possibly, certainly by high school, and a lot of it has to do with obesity. You never used to see patients who were diabetic until they're 30 or 40. So it doesn't surprise me now to see them when they're in their teens.
This is nothing new. I mean, for 10, 15 years, we've known that there's a public health emergency with regards to diabetes, and the curve is not necessarily being bent fast enough to try and drop that down. We're still seeing certain areas of our population have increasing numbers of diabetes. The good thing is because it's been a focus for so many years, and it's been an important focus, is we're learning more about early intervention and prevention, which is really the key to getting rid of all the downstream effects. And the primary care, the eye care someone with diabetes our guideline also talks about people at risk for diabetes. And I think that's a really important part of the initial guideline and also this new revision with new evidence engaged in it. One of the important pieces of the diabetes guideline, and this is maintained in the revision, talks about the demographics. It talks about the impacts, how many people are affected. Since the last guideline was done, there's, as you know, more of an impact now on children and people in their younger years. So it gives a framing and important evidence to support the question of why does it matter? Why should we care? And we know, from my perspective, I've seen people with diabetes all throughout my clinical career. It's the number one cause of people having newly diagnosed legal blindness. It results in all sorts of different devastating types of vision loss. It's devastating because it's not just a one-factor kind of condition.
Can we talk about what an evidence-based clinical practice guideline is?
A clinical practice guideline is an evidence-based document that science and research has shown of how to treat a general medical condition, and in this case, diabetic retinopathy and diabetic eye disease. It's a process that the committee will go through in terms to determine the whole document. First of all, the questions will arise. They get together and they decide what questions are asked. Then they go and research articles that answers these questions. That process is done by usually a librarian or someone who can do research throughout the whole medical literature. And as a general rule, there's a 10-year span of literature that's being looked at. The process then goes from there in that these articles are read, they're given a grade, and they're given a recommendation. This now becomes instead of being a consensus article, it becomes a scientifically based article because all the recommendations are based on scientific evidence as displayed in the literature. A consensus article is basically where a group of people read some articles and come up with their consensus of opinion.
One of the things that we know is a guideline is not a blueprint for what has to be done. A guideline is there to augment and supplement the clinical decision-making of the doctor and together with the patient to help them make the best healthcare decisions for that individual. There is no one way of treating a particular patient with diabetes, just like there is no one way of treating someone with any other kind of health condition or disease. And it gives them the power of information, and that's really what the focus is.
So the thought is that it's a stronger argument or stronger policy, or standards are being set based on evidence, not just on educated opinions.
It is scientifically based, and it's been proven technology, so to speak.
And the EBO committee itself?
The Evidence-Based Optometry Committee basically consists of a chair, a co-chair, and member doctors who are optometrists, but it also includes experts, retinal specialists, an internal medicine physician, and a person who's a stakeholder who's also diabetic. These are doctors from all different walks of life. Many of them are in academia, some of us are in private practices, and the patient who is a stakeholder has been diabetic for a number of years. So we get a fairly broad-based representation on the committee.
You mentioned private stakeholders. What is their contribution?
Their contribution is basically to let us know the other side of the coin. We're all physicians and we know what happens on the physician side. We want to know, how does the patient or the stakeholder actually sees this process going? What do they like, and what's their opinion in terms of the quality of care that they get, and in terms of, more the touch and feel side of the condition.
In the past, I've looked at the number of hours that go into the 14-step process for developing guidelines. It's thousands of volunteer hours, from research to grading evidence and coming up with the recommendations for care. And that's even before you write a draft guideline that is reviewed by peers, the AOA Board of Trustees, and even legal counsel.
The current guidelines, I think we've read between about 650 papers. Those papers can take anywhere from an hour to an hour and a half to review, or to read, review, and grade. So if you add those hours, it tells you how many hours it takes to get through this process, and that's just the reading part. More time is spent in putting this information together, and typically we'll have, for the diabetic guidelines, I think we've had about 3 or 4, we had about 2 face-to-face meetings and numerous Zoom meetings, which is, evening consultation with each other. So yes, it does take a lot of time, but it is a dedicated committee who enjoys the process and, as such, puts the time in.
It is a true labor of love to be engaged in this process. The good news is that if you look online at any of our evidence-based guidelines, that in the very beginning we outline exactly what our steps are, what the process was. And just reading that little table that highlights what the process was can be very eye-opening. We start off by doing a comprehensive systematic review of the literature, and this is based on key questions we ask and keywords, and searching all available portals or search engines and gray literature and the whole bit. So it's an intensive process just to get to the point where we've narrowed down the literature that we want to read. And at the point that we first started, I think there were maybe 10 of us on the committee, 8 or 10 of us, and we were reading 20, 30 papers a month sometimes just to get through what we needed to do. Now, it usually wasn't quite that extreme, but there were times when it was big, especially through the first guideline. We were kind of learning our way and feeling it out and seeing what process worked well. One of the reasons we have a larger committee today is because of what we learned early on. We needed more people power. Yes. So we spent hours reading and grading papers. So part of the process was educating the committee on how to critically read and grade a paper. And we would take a look at that. We would have agreed to standards on what ratings were, A, B, C, or D. We actually had to come up with different criteria for when bias was engaged and how to report that. We had to learn how to dissect methods in the papers, and if you were not heavily into methodology, that could be a challenge. So one of the roles that I played was early on was as a methodologist to kind of help in that regard. But we had a lot of smart people there, and they all came along really quickly. And we currently have an incredibly talented group of people that do this. And then it was very important to work with our writer. Stephen, as our writer, was very, very critical, because if we had information that wasn't necessarily going to result in an action item or in a part of a content within the outline, we had to use it as background information, or we wanted to include it, but we wanted to make sure that it was there more as a reference, then he had to find a way to help us embed that into the guideline.
So even the materials you don't necessarily use to come to your findings, it's recorded in some fashion.
Correct. And so any paper that we've read, we have to document what transpired, what we did with that paper. So if a paper was utilized, it's listed. If a paper was thrown out for some reason, we found out that it really wasn't relevant, or that the level of evidence, the quality was so poor that it was just not usable, we had to keep track of all that, and that's part of the process that's spelled out. And in each of the guidelines, you can see how many papers were read and how many were utilized and what was titrated down into the material that formed the basis of the guideline.
How does the guideline benefit doctors and patients?
Let's just say the optometric physician has very little knowledge of diabetes. They can go to the guideline, and the guideline is a step-by-step instruction, so to speak, of how to take care of these patients. It talks about the prevalence. It talks about diabetes, the type 1 and type 2, what affects them. It talks about the studies that studies these different conditions and what affects better outcome. And that's where, instead of the doctor sort of going through blindly, there's a roadmap now that they can go through and follow step by step and become more educated and a better provider of care to these patients.
Advocacy cross-cuts everything that we do. It's not just being at a legislature. One of the important roles of a guideline like this, though, is very much usable at a legislative level. So when you look at advocacy from the legislative, regulatory side, these guidelines give weight and merit and evidence to support arguments that we make with regards to scope expansion, with regards to delivery of care, with regards to health policy. That's one of the key roles of a guideline, is to present evidence for people to utilize, and using it in that fashion is something that I hope, and I know we've heard wonderful feedback on from our affiliates, that they're usable and they're needed in that regard, because it gives people something to point to say, I'm asking you to do A because of B, and here's my evidence to support that. We also use guidelines in developing health policy. The guidelines are incredibly useful for in the clinical setting for doctors to make good clinical decisions. So clinical decision making is all about using appropriate, all available data to make decisions in conjunction with patients to get the best outcomes, incorporate patient preferences, and utilize the best available evidence. And that's what these guidelines help to do. They're another tool for doctors. We know from the health services research area that I have trained in, we know that the best way to obtain the best health outcomes is to make shared decisions with your patients. And that clinical decision-making piece is enhanced with evidence and tools. And guidelines are a critical part of giving doctors the tools that they need to help bring evidence to the table when making those decisions with patients for treatment options.
Well, it helps the patient indirectly because now the doctor has a roadmap by which to look at these patients. It is for public consumption, especially for the family who has a history of diabetes, because, what do we learn from? Well, my grandfather or my mom has such and such. But it never tells you what you can do to prevent some of those events. And that's where I think this guideline will help the public. It'll say, okay, you have to get your eyes checked, you've got to watch your diet, you've got to get your exercise. And you don't wait until the event occurs or damage is already done, then jump on the bandwagon. That's where the public can be helped.
Let's talk more about the role of optometry in making an impact on diabetes.
Actually, there's a huge role of the doctors of optometry because, as a general rule, the average patient sees their eye doctors much more common than their family doctor, or more often than their family doctor or any specialist. So it presents a very good opportunity for optometrists to be able to talk to them about their diabetes, about their health, and about what they're doing in terms of testing, in terms of their exercise program, or anything of that sort. There's also a greater affinity of optometrists with their patients, meaning they typically see them longer. They have a greater relationship, so they can speak more, openly with their doctors. As such, optometry needs to take the role of being the eye care provider for these patients because no one else will. As a general rule, ophthalmology doesn't seem to emphasize the care of diabetic eye disease because of their surgical skills. If optometry doesn't do this, the chances is that internal medicine will embark on this because there's a trend right now where there's these clinics are actually installing retinal cameras to do screenings. The optometrist can do a better role of doing that because they can dilate the eyes, they can assess the concerns and address that with the patient as well.
How about the contents of the guideline?
A couple of things that's unique about this guidelines from the physician standpoint is they outline many of the major studies and what the conclusions are. So now you have a quick reference of the ETDRS study or the DCCT study. If you want to know what those studies are, you go to these guidelines and you'll find it. They talk about the medications. Now, the only problem with that is medications are changing almost every day. But this gives you a basis of what's out there, what the implications are, what the dosage is, and how it affects diabetes. We talk about what can you see in the back of the eye, the retinopathy that's there. Now in this document, you're able to see those pictures, so you have a reference of what to look for.
So what do ODs see during dilated comprehensive eye exams?
Well, generally by dilating the eyes, you open up the pupils so that you're able to see more. Think about it, looking into a room through the keyhole versus opening up the door and looking into that room. You can see a lot more details. You will see lots more. You can typically see further out in the periphery, meaning you'll be able to see much more of the retina. You'll be able to see more details of the macula as well. You can see multiple things. You can see bleeding, you can see nicking of the blood vessels, you can see cotton wool spots. You can see areas where bleeding has occurred and resolved. So there's a lot of things that you can see by having the eyes dilated.
So, I imagine para-optometrics also have a role in diabetes care?
Absolutely. That one of the most important facets of our healthcare teams in our offices are the folks that help us care for patients. And para-optometrics are an incredibly important part of our team. Usually the front line on the phone. They're usually the first person that an individual will see when they come into the office. Having a well-engaged team in the office is not just the doc running the ship. It's having everybody on board be on the same page and understanding what the negative impacts can be of diseases like diabetes. And so I would certainly encourage every doc and everyone on their team to have a copy of this printed out. If they don't have easy access to the online document, to use it as reference, to have office meetings and talk about bits and pieces of the guideline over time. It's a long guideline, and it can be a little overwhelming, especially if this is a new foray into understanding diabetes. So it's something you can break up and you can help share with your team. Para-ops can kind of work with each other and train staff and kind of develop this, if you even wanted to, a specialty practice dedicated to patients with diabetes. There's a lot of docs in the House of Medicine that do that. Endocrinologists and other folks have very high numbers of patient census numbers with diabetes, and there's several optometrists that I can think of off the top of my head that do the same, but we need more. And so that would be a great opportunity for them to read it, engage it, and make sure that everyone in the care team understands it.
So, in the end, with this new guideline, doctors of optometry will be able to have an even greater impact on the lives of patients and the nation's health.
We've been out there on the front lines for so long doing this that it makes perfect sense. We're accessible in so many counties across the country where other doctors are not available that we can play a greater role. So maybe looking at having a way to evaluate A1C and glucose in the office and being able to monitor and track that over time, being able to help people with diabetes education and behavioral modifications and in ways of controlling either getting the onset or preventing, the bad effects of having diabetes. So to your point, I think it'll be interesting over the next 5 to 10 years to see where optometry goes, but we certainly play an important role. We can play a bigger role, and I think it would behoove our nation's health to have doctors of optometry more engaged in the care of diabetes.
Well, thanks for talking about the updated diabetes guideline and how it can make a tremendous difference to doctors and to patients.
You're welcome.
You are more than welcome, and I want to thank you for inviting me to talk about it. And I encourage everyone to go online and search for AOA.org/guidelines, and they'll all be available right online.